Okay, so we're on to rhythm. Rate is a no-brainer, right? What was our 300 rule?
75,
Yeah.
60.
What's after 150?
Not 75.
Not 75. 100, then 75, 60, 50. 300, 150, 100, 75, 60, 50. Excellent. Each one of the large boxes, starting from a QRS complex that overlays one of the major grid lines, counting successively. Or you can measure them, or if you have the ticks at the top of the ECG trace, you're lucky to have that paper, then you can ballpark it with the 6-second rule. But rhythm, no problem. Or sorry, rate, no problem. Rhythm we introduced, we looked at the hierarchy of the nodes dictating rhythm of the heart. And we talked about how normally conduction goes in a certain order and overrides the slower pacemakers at the bottom, but if there's ever a block, and this is a concrete block, but there are different levels of block. Remember, there's delay or intermittent block or complete block, but if there's something wrong with signal transduction at the different levels, that can result in a few different characteristics that we'll look at today. So if we start just with the SA node, which is the prime pacemaker of the heart, if something's wrong with the SA node and the other atrial foci are setting heart rate, or there's multiple foci trying to set heart rate, we can observe at least these 3 characteristic ECG traces. And there's a lot more, but we're going to look at these 3 as indicators of varying degree of block. So the first example is the wandering pacemaker. And it's exactly as the name would imply. The SA node, which is normally the major pacemaker, is not consistently active. And so other sites can start to generate the electrical potential in the heart. It wanders through the atria. There's at least 2 sites that serve as pacemaker in this example. And because there are multiple sites, the timing and the shape of the P waves changes. A normal ordered P wave will start with the SA node moving to the AV node. We know how the electrical signal will be conducted, we know the timing, but if there's multiple sites, that changes. So the shape changes. The spacing between the P wave and the QRS complex changes. Or the spacing between the T wave of a previous cycle and the P wave of a new heartbeat will always change. So you might see flattened P waves. Normally, we know they're nice, rounded bell curves almost. They might be notched. They might be biphasic, so they go up and down. They might be flattened. And as we can see here, there's intermittent, or the spacing between the P waves changes. It's not regular. So they're irregularly spaced. The shapes are pretty consistent here, but we'll see examples in the on the next examples in the next example of different shaped P waves. You can also observe some junctional rhythms, junctional escape rhythm, where the AV node dictates pace. If the space between the P wave and the QRS complex is too large, that gives the AV node enough time to spontaneously depolarize. So because the pacemaker wanders, there's no one consistent place that always initiates contraction. It may allow for the AV node to dictate pace. So wandering pacemaker. You can also think of this as multifocal atrial rhythm, which if you break down the name is simply multiple foci, different origins, atrial in the atria, and rhythm indicating here that the heart rate or the rate of depolarization is less than 100 beats per minute. And I only present that because the next example is multifocal atrial tachycardia. There's only one small change as we move to the next example. So varying durations and spaces of P waves, often different shapes of the P waves. You'll also notice the rhythm is not exactly consistent. It's a bit irregular. There are faster beats here, slower beats here. And because of that irregularity, sometimes you can confuse this with atrial fibrillation, our third example. When we get to that example, I'll show you why it's not obviously or easy to confuse. Fibrillation is a much more disorganized, erratic, chaotic trace. And the defining feature is that there are no P waves in fibrillation, but we'll get to that. So wandering pacemaker, multifocal atrial rhythm, in contrast to multifocal atrial tachycardia, which is shown here. And the difference is the pace is over 100 beats per minute. Now the reason that this occurs is not really well defined, or at least it's outside of the scope of our interest in this course. Often these will all relate to ion imbalances, and more frequently it's potassium, but multifocal atrial tachycardia seems to be related to some overflow in calcium, which is our main signal to initiate contraction. You have at least 3 distinct P waves, multiple foci that trigger depolarization, and they are characterized by their obviously different shapes that I've highlighted here. So we see a large rounded P wave on the far left. We see the notched or bimodal P wave in the middle, and then a short spiked P wave highlighted on the right. So 3 different types of P waves that are clear and obvious, indicating different locations in the heart trying to initiate contraction. Now the reason it's called tachycardia, like I mentioned before, is only because the heart rate's over 100 beats per minute. And you can kind of think about the distribution as follows. If it's bradycardia, the heart rate is less than 60. Normal is within the range of 60 to 100, and then tachycardia is simply anything over. So we just name for the rate the high accelerated heart rate here, and the nature, the multifocal nature, is described by the multiple P waves. So different foci activating. The signal obviously gets through. It's relayed by the AV node, because for every P wave there is a paired QRS complex. So the whole heart does depolarize. The ventricles contract. The signal gets through, which is not the case all the time. Even the wandering pacemaker, not all the P waves get through. And it's I threw this up because it connects to COPD that we mentioned in our last section. This is a characteristic that's often present with medicated individuals that have COPD. So one of the treatments for COPD is theophylline, which is a bronchial relaxant to help to open up the airways and reduce airway constriction, reduce airway resistance. And in doing that, yes, you help deliver more oxygenated air to the alveoli, but the heart cells seem to be aggravated by theophylline, which is a caffeine derivative. It's often found in tea, black tea, and it has this stimulatory effect on the heart, and in high doses can cause or is related to multifocal atrial tachycardia. So an unfortunate side effect of treatment for COPD, this is something that you'd have to watch for in those individuals as well. Now the third example, which is obviously different than the rest, is atrial fibrillation, and you can see the chaotic nature of fibrillation shown here. Specifically, a very disorganized electrical series of signals. There's no clear hierarchy. There's no firing of nodes in the atria and then the ventricles. There's this scattered, fragmented almost buzzy sort of background noise. And it's really indicative of atrial spasm. So the atria are sort of quivering. They're not uniformly contracting and sending electrical signals through the heart. We have infrequent passage of the potential to the ventricles, which is good. We do see some depolarization. It's hard to say if these are junctional escape rhythms, but because they seem to accelerate over here, I'm not gonna hang my hat on the fact that the AV node is only responsible for depolarizing the heart. Infrequent passage is indicative of the AV nodes still work. So even though we have atrial fibrillation, not all of that fibrillation, not all of those chaotic signals get through. We still have some beating of the ventricles, which would work to still pump blood. So we don't have disorganized disengagement of the heart and the ability to pump blood, which is, I think, what, Kristen, did you mention that last class? The idea that the AV node tends to slow down the impulse as it goes through the heart. So we still have that here. You did mention that, right? Yeah. We still see that here. There's infrequent passage, and we have obvious, at least S waves in the QRS complex that show ventricular depolarization, but the atria are in fibrillation here. There's no clear P wave and lots of just messy noise in the background. So no well-defined P waves.
What do they do upstairs?
Well, class is done. We're in that weird block, so yeah, they're all leaving. Or they have like one of those round table discussions set up. I'm not sure. So irregular contractions, the R to R space is not consistent. We also see narrow QRS complexes in this example, which is indicative of a normal bundle branch functioning. So it's not upstream, or sorry, it's not downstream of the AV node. This will become more clear as we talk about bundle branch blocks later. But if we have a nice, quick, short, thin QRS complex, that means that transmission once you get to the AV node is normal. If this were elongated and wider, transmission through the AV node or the bundle branches would be somehow impeded. So a few examples of where the SA node or the atria either disengage from the firing of the AV nodes, or multiple foci try to activate contraction of the heart, or where there's no organized activity in the atria and the ventricles are almost themselves being relied on to allow blood flow or promote blood flow. So if we move down and there's some delay between the atria and the ventricles, this could be just proximal to the AV node, to the junction. It could be in the AV node, or it might even be just after the AV node. The AV node itself we think of as just a cluster of cells, but it connects directly to the two bundle branches that split off and run down the septum. And technically, where the bundle branches split can be part of the junctional block. But if there's some disruption here that essentially disconnects the two halves of the heart or doesn't link them continuously, this is what we call AV block or junctional block. The first obvious example where we have disconnection of atrial firing and ventricular firing is if something's wrong with the SA node or the atrial foci where there is no activation of the atria. And in this case, if there's no activation of the atria, we see no P waves. The characteristic lead 2 trace, which has P waves, QRS complexes, and then T waves at the end, shows no P waves, indicating absolutely no atrial firing. We're relying only on ventricular firing to maintain heart rate in this case. Consistent junctional escape rhythm. So this could be continuous block of the SA node or damage to the SA node. So we're relying only on the AV node as being the pacemaker of the heart. Now this same setup can occur in our second example, where instead of not observing a P wave, we observe an inverted P wave. And this simply indicates to us that the AV node's initiating contraction, the signal is being generated and sent through to the ventricles, but it's also being sent retrograde back up into the atria towards the SA node. So the atria are depolarizing. They're just depolarizing in reverse. Positive wave away from the positive electrode, because it's being initiated at the AV node and traveling back towards the top of the heart. So it's possible, even just comparing these two examples, that in the second example, it looks pretty clear that the electrical system is intact. There's a connection between the atria and the AV node. Otherwise, we wouldn't see any P wave. And in fact, in the first example, that implies to us that there's some disconnection between the conduction system and the atria and the ventricles. The signal starts in the AV node and then doesn't end up anywhere in the ventricles. There's no contraction. Now these are examples of what I would affectionately refer to as proximal AV block. Yeah,
so
go ahead.
The no P wave, is that more like fatal than the wave?
I wouldn't say it's more fatal. I wouldn't say either of these is necessarily fatal. They both result in no atrial contraction to aid in the pumping of blood. So it disconnects atrial pumping from ventricular pumping. Even in the second example, where the atria contract, the ventricles are contracting, so the valves are closed. There's no more blood getting into the ventricles to be circulated.
So it doesn't matter that the atria are contracting in that second one?
It doesn't matter. No.
Not before.
It's not before. It doesn't matter. Yeah, good call. Yeah.
So if the atria are contracting while the ventricles are contracting, does that result in like degradation of the valves, or like would that cause any like extra wear and tear on the?
Interesting question. Okay, so degradation of the valves. You have to think, is there any extra pressure on the valves that there would not normally be? And I think the relative contribution of the atria contracting to pressure on the valves is so much lower than the ventricles contracting and exerting pressure on the valves that I can't imagine it would accelerate it too much. But it's possible. It's a great line of thinking, and I don't know the answer to that, but I would guess probably not, because the valves are already set up to handle the pressure generated from the ventricles. Do you know what I mean?
That would be coming from the opposite direction.
It would. And if that's the way you think about it, then it would offset any pressure generated in the atria. So the pressure in the ventricles would serve to anchor and seat the valves to help them rebuff any pressure in the atria. And almost create more of a stable foundation. It's a great thought, though. Yeah, maybe it's beneficial. No, we'll see, though, if we disconnect the two completely, and there's complete AV block, so no signal gets through, that's actually fatal. We don't want that. Third degree block is the complete disconnection of the atria and the ventricles, and is typically fatal where if you don't have a pacemaker to regulate contraction, there's no organized pumping of blood. So if those are proximal AV blocks, and I use block loosely in that sense, these first, second, and third degree block are intrinsic to the AV node. So the AV node has the property of transmitting and somewhat delaying the signal from the atria to allow organized temporal contraction of the heart. That signal can be delayed more than normal. That signal can be prevented occasionally or that signal can be prevented always. And those are examples of blocks of increasing severity, and we call them first degree, second degree, and third degree AV block. So the passage of the signal from the atria to the ventricles is blocked with increasing severity in these examples. So first degree block, where conduction is delayed, is fairly simple, and it only presents as an elongated PR interval, which makes sense because that represents the transit time for the signal from the atria to the ventricles. Here it's slightly longer than normal, and we call longer than normal anything longer than or greater than one large box, 200 milliseconds. So the PR interval being measured from the start of the P wave to the start of the QRS complex is how long it would take for the signal to move through the atria to or be processed at the AV node and then be relayed and sent through the ventricles. Anything longer than one box, and in this case it's one box and maybe 3 small boxes, something like that, with 320 milliseconds, is an indicator that the conduction is delayed. And that would simply be reflective of first degree AV block. So not life-threatening here at all, just a longer signal or a longer delay before the ventricles contract. Now, in order of increasing severity, we're going to discuss them in order of increasing severity, but you can think of the potential causes as also being increasingly severe. So the things that might cause this delay in the AV node would be sometimes increased vagal tone, like you get with athletes, might cause this delay at the AV node. It's also possibly related then to a slow intrinsic heart rate, which is a result of increased vagal tone. Or physical disease or damage to the AV node. Some congenital blocks result or used to result when lupus was a problem, and the mother would generate antibodies to fight off lupus that also specifically targeted fetal heart tissue. And the fetal heart tissue seemed to be related to the AV node, so some of these AV blocks are congenital because of the occurrence of those antibodies in the womb. I'm not saying that's always the case, but it's interesting to note that some of these causes can be somewhat out of left field. So any damage to the AV node, infarction, lupus as an example, or a low intrinsic heart rate with increased vagal tone might delay the signal from being relayed. Generally, this is fixed. First degree AV node is always a delayed transmission of the signal. If it's not fixed, if the delay is variable, it's indicative of second degree AV block. Second degree AV block. So this is delay of the signal at the AV node and sporadic non-conduction. Sporadic blockage of the signal. In other words, most of the signals get through, but sometimes one will not get through. Now within AV block, or the second degree AV block, there are 2 types. The first type is what I'm describing here. There is an increasing delay to the point where the delay is too long and there's no signal getting through to the ventricles. Eventually the cardiac cycle resets and that delay increases again. So we see the PR interval very short over on the far left side, increasing in duration until there's no passage of signal and no contraction of the ventricles. This is the most benign type. It's called Morbitz type 1, or I think you call that Wenckebach. I'm not exactly sure. I'm just going to call them type 1 second degree AV block, and type 2 second degree AV block. And this is where our inclination as humans to organize things just gets overly complicated. First degree, second degree, type 1, type 2, AV block, SA block. There's a lot of different degrees of hierarchy, but I'll call these type 1 and type 2, and we'll leave our discussion there. So type 1, the most benign. This increasing delay will reset, and it doesn't aggravate the cardiac cycle any more than you see here. There's little chance of cardiac insufficiency or fibrillation or this progressing to anything more severe. There's just this increasing delay and the occasional skipped beat. And the most common treatment for this is just to install an artificial pacemaker, which will set the cardiac cycle and fix the PR interval. The second type is not increasing delay resulting in non-conduction. This is simply fixed non-conduction. There's always some signals that don't get through, and in this example, the majority of signals, perhaps 2 out of 3 signals, are not transmitted through the AV node. So we have a problem here where the signal to contract is not being received. The AV node is only responsive to 1 out of every 3 upstream signals, and the heart only beats 1 out of every 3 times that the cardiac cycle attempts to initiate. And so this can quickly deteriorate into complete heart block. Here we have at least some signal getting through. We have an occasional ventricular beat. If this were ever completely blocked, this can suddenly lead to cardiac arrest, disorganized pumping of blood, sudden cardiac death, heart attack. And so the treatment here is to make sure that regardless of whether the signal is sensed or not and the ventricles contract, we want the ventricles to contract. So we install an AV node pacemaker to make sure that there's always a QRS complex at regular intervals pumping blood to the rest of the body. We can't always align the pacemaker with the atrial signal. We can't always align the QRS complex with the P wave. And so when I show you complete heart block or complete disengagement of the atria from the ventricles, that is complete non-functioning of the AV node, which would be no QRS complexes if you could ever observe that trace. Instead, what I'm showing you here is the treated version of second degree AV block. Third degree AV block is theoretical. It doesn't actually happen because if it does, you die shortly thereafter. If you have absolutely no signal being generated or conducted from the AV node through to the ventricles, and there's no heart contraction, there's no blood moving to the rest of the body. So what I'm showing you in this complete heart block scenario is a treated complete heart block. So death results if you have complete block and you don't install a pacemaker. Often you'll attempt to do this before the person or while the person exhibits second degree block before it deteriorates completely. And you can see here 2 separate rhythms. There's one rhythm initiated at the atria, a second rhythm initiated at the pacemaker in the AV node. And if you were to tease it out, like I'm going to do for you here, the P to P interval is obvious once you highlight it. So we have defined P waves that are occasionally overwritten and lost with the large electrical activity of the ventricles firing. But you can see them at regular intervals. You can see it somewhat overlapped on top of the T wave over here, before the T wave. But regular firing of the atria, which in contrast to ventricular depolarization, as shown here, is not synced, it's not lined up. There's complete dissociation of the rhythm of the ventricles and the atria firing. And that dissociation is because of the AV pacemaker that initiates the QRS complexes. So we have this much slower but still regular ventricular depolarization highlighted in blue. And that might be something like 40 beats per minute, which now that I'm thinking about it is quite low. I don't know if that's supposed to be the case. If you want your pacemaker to run at only 40 beats per minute. Anyways, the point of this slide is to show you that the two rhythms are separated, are divorced completely. Any questions about that before we move on? This is still going to be a discussion of AV node block, but we're just moving a little bit more distal. Yeah, Leanne.
Would that be someone who had second-degree block and then got an AV pacemaker and then it just progressed to third degree?
Yes, that's exactly what it is. Yeah, good idea. This is second-degree block that's been treated. On this slide, second-degree block here is untreated, and we see infrequent transmission of the signal through to the ventricles, which would deteriorate in time to eventually no signal getting through to the ventricles. And before that happens, we install or surgically implant the AV pacemaker, which dictates ventricular rhythm independent of atrial rhythm to prevent that complete disconnection and inadequate pumping of blood. And death. That's another side effect that you want to avoid. So this is intrinsic to the AV node itself. Yeah, you have a question?
Just to build on to our idea, so if the second degree was treated, does that mean the individual has two pacemakers?
If the second degree was treated, the pacemaker is in the AV node only. So the block is at the AV node, at the junction, the point where the atria meet the ventricles. The SA node's fine. You can see in the second degree block regular P waves. The SA node's fine. The signal doesn't get through, so the problem lies at the AV node.
So did you just, when it escalated to third degree, did you just fix it?
So third degree block this is treated second degree. Third degree block would be complete dissociation with no ventricular pumping. I can't show you a trace for third degree block because it would just be a flat line. So if second degree escalates, deteriorates, and becomes third degree block, it has to be treated. And this is a trace of the treated second degree, or treated third degree, but third degree is theoretical. It's not possible to demonstrate in a living person. Good clarification, though. It is important, I think, to understand that these two are intimately related and they are somewhat connected. So if we move a little bit more inferior, and we don't focus necessarily on the AV node itself, but now I want to take a look at the bundle branches and other locations within the ventricles. We can observe some situations where the ventricles themselves might initiate depolarization. And the classic example is the premature ventricular contraction, which is often experienced by some elite athletes or some individuals as they fall asleep when the rhythm of the heart naturally slows down and the signal from the SA node is too slow the ventricles themselves depolarize. Nothing really happens. There's nothing bad about this. This simply resets the normal electrical rhythm of the heart. And we have, except for this one instance where we observe a PVC, we have normal sinus rhythm. We have P waves, QRS complexes, and T waves all in a normal rhythm and order. The durations are appropriate, but for some reason, the ventricular foci here activate, and we see this large spasming of the ventricles that is eventually reset. So normal premature ventricular contraction doesn't necessarily cause anything bad. This resets. It's fairly common. You might see it in 1 to 4% of the population. Even those that are not athletic, if they're really relaxed, might demonstrate a PVC. So it's just a momentary reduction in flow. Nothing too serious downstream. If it's not momentary, the subject exhibits what we call an idioventricular rhythm, which you can think of as regular premature ventricular contractions, regular PVCs. You can see, I'll try to highlight them here, regular premature ventricular contractions, highlighted in the green boxes, where we have otherwise normal sinus rhythm that is interrupted at regular intervals by the ventricles firing. So the question is, why would, well actually I'll ask this question in 2 or 3 slides, but start thinking of why the ventricles would fire themselves. There are a few different reasons, and we'll talk about a couple of the ion imbalances that might occur that allow the ventricles to fire. Why might the ventricles fire themselves? A characteristic of these kinds of waves are we start to see a widening of the QRS complex, or of the premature ventricular contraction. We still see some normal QRS complexes here that are thin, that are regular, that are closely related to the T waves, and in most cases P waves. But these PVCs start to widen. And the widening is indicative of the electrical signal traveling through the muscle tissue itself. Normally the signal is sent through the conduction system of the heart, which is purposefully designed to quickly transmit the signal for contraction. But we start to see a wide QRS complex whenever that signal doesn't go only through the conduction pathway, but spreads through adjacent cells. That often happens if contraction is initiated from foci that are not immediately on the conduction pathway or related to the conduction pathway. Walls of the ventricles, for instance, might initiate these cell-to-cell depolarizations. So we have fixed, regular PVCs, but again, normal rhythm is maintained for the most part. You do have some disruption in flow, but you still get an adequate flow. Perhaps not to sustain high exercise, high intensity exercise, but you can live with an idioventricular rhythm. It's a lot harder to live if you have disorganized ventricular contraction, or the firing of multiple foci in the ventricles. And the first instance of that is what we call ventricular flutter. Flutter. Flutter is different from fibrillation. Fibrillation is the next example. And flutter is random, disorganized pulsing or contraction of the ventricles. This is a transition between what we would think of as tachycardia, really fast heart rate, and then fibrillation, which would be disorganized heart rate. This is a transition between those two. So large rhythmical ventricular contraction that involves here one focus that's not involved in the normal conduction pathway that sends disorganized electrical signals through the heart, and it ends up looking like a sine wave. There's no clear features of depolarization or normal contraction. We just see this large back and forth spread of electrical activity through the heart. And so with this disorganized electrical activity, of course, there's disorganized blood flow as well, but there's a little bit of blood flow. This is the precursor to cardiac arrest and not sustainable long term. Cardiac arrest is indicated here as ventricular fibrillation, or quick sudden cardiac death, cardiac arrest. The flutter has deteriorated to almost just a buzzing or quiver of the heart tissue. You still have that same undulating, disorganized electrical activity, but there's not even any rhythmic pulsing of the heart in this case. It's just static quiver, almost a tetanic contraction of the heart muscle. There's no pumping of blood. There's just shaking of the heart tissue. So the difference between these two is in these boxes where flutter is rhythmical disorganized contraction, fibrillation is chaotic. There's spikes, there's no rhythm to it, there's no organization, it's just quivering of the heart muscle, the heart tissue, and no pumping of blood. And so the treatment for this is defibrillation. The paddles you always see on TV to abruptly disengage all the electrical activity, cease all electrical firing, and then hope that the normal pacemakers in the cell will pick back up and initiate contraction. If we reset all of the cells in the heart, we make them all enter their refractory periods, then all of a sudden the pacemakers with the fastest intrinsic rate should be able to fire and spontaneously initiate contraction. We're hoping that's the SA node, and that we see organized P wave, QRS wave, and T waves afterwards. But without that, you might be able to stay alive for a few minutes, but not much. There's no organized pumping of blood. So why would the ventricular foci activate? So why would the walls of the ventricles activate? One common example that's actually been only well studied recently is the idea that hypoxia causes premature ventricular contractions or irritation of ventricular foci. Like any cell, with less oxygen than you would want, you rely on some substrate level phosphorylation, and our counterpart in the back could tell us more about reactive oxygen species, but there's some disorganized mitochondrial metabolism that ends up affecting the calcium channels that we discussed that are responsible for the plateau phase. So remember, the plateau phase of the depolarization cycle was to allow calcium to rush in, to engage contraction of the cardiac tissue, and squeeze the cardiac tissue. So hypoxia aggravates those calcium channels specifically and prevents the plateau from occurring. So we get this unsatisfying, incomplete contraction, if you will, or unsatisfying depolarization. So that's one reason that we think a low PO2 or hypoxia can aggravate the ventricular foci. I looked at a review before coming to class because I wanted to know more about this, and there's a lot more information, but we're going to leave our discussion there. A second popular candidate example is alterations in blood potassium, and specifically low blood potassium or hypokalemia. So normally blood potassium is low. We have some circulating, but in general extracellular potassium is quite low. If this is lower than expected, then the drive for potassium to leave the cell is greater, right? The concentration gradient is much higher. Maybe not much higher, but it's certainly higher. So the drive for potassium to leave might cause accelerated leakage. An accelerated leakage of potassium out of the cell would bring membrane potential up, and it might spontaneously trigger more easily. So low blood potassium can aggravate ventricular foci as well. Blood potassium or extracellular potassium is generally something you don't want to mess with though, because hyperkalemia, the opposite, can also influence the conduction cycle and heart rate. Generally, contraction is slower and more drawn out because the movement of potassium is hindered as it leaves the cell. It's a different series of problems, but we want to maintain blood potassium within a tight range that I won't get to here because I can't remember the numbers off the top of my head. But you don't want to overdose or underdose on potassium, specifically for arrhythmia reasons. There's also physical pathologies that can affect the conduction system and aggravate the ventricular foci. So this Wolff-Parkinson-White syndrome is where there is an extra pathway in the heart, where the electrical conduction pathway loops back around and reconnects to the AV node. And so it's almost like a circular feedback loop where one heartbeat will initiate the next one prematurely through conduction of the signal by the ventricles and then through this new electrical pathway. And it's rare. It's not a common occurrence, but I don't want to say it's easy to diagnose, but there are some characteristic traits that make the diagnosis more likely. And it's this, you can't even really see it. Let me take that box off. It's this delta wave at the bottom right, and the delta wave is simply this slurred, graded upswing of the QRS wave, or the QRS complex. So normally we have a very quick, steep upslope or upstroke of the QRS complex, but this is a much more graded, gradual, elevated, slurred portion of the QRS complex. And this doesn't happen very often, and it usually only happens when the electrical signal loops back around and reactivates the AV node. It's very infrequent, but it's another example of why ventricular foci might activate. Or if there's some blockage at the or delay at the AV node, then we allow the intrinsic depolarization of the ventricles to occur. If there's heart block, or if there's an artificial pacemaker, ventricular foci will activate because the pacemaker might send the signal for them to initiate or activate first. Now, we've talked about the node as a collection of cells, and there is another class of block below the AV node. Anything below that we referred to as the Infra-Hisian Block. But I really only want to focus on one type of Infra-Hisian block called the left bundle branch block. But literally this means anything below the bundle of His, the connection point where the branches meet the AV node. In general, this will relate to either left or right bundle branch block, but I'm going to focus on left, being that left is the largest ventricle, the one that we're concerned about for pumping blood to the rest of the body. And the delay in contraction, or the delay in the signal, results in conduction of electrical activity through the muscles of the heart, much like we saw with the premature ventricular contractions. So if there's a block in the bundled branch, specifically on the left side, but this can also happen on the right side, then the signal to contract that side of the heart doesn't arrive through the conduction pathways. It has to arrive from somewhere else. And so we circumvent the broken bundle branch, the broken electrical pathway, by sending that signal through the heart tissue. So we have automatically a wide QRS complex. Whether the block is in the right or the left bundle branch, or both, the QRS complex is wider than normal. Now I'm focusing on the left bundle branch block because it's a form of the type 2 second degree AV block, where we have infrequent transmission of action potentials to the ventricles. There's regular fixed non-conduction, and generally blocking the left bundle branch is the reason why we have that regular fixed non-conduction. This is most commonly associated with that second degree AV block, and we think this can progress to complete heart block if we don't install that AV pacemaker and then circumvent the block. So I'll show you what I mean by bundle branch block. If we use this stylized cartoon drawing to show the SA node, the AV node, the normal conduction pathway in the heart, we have the bundle of His, and then the bundle branches coming off of it. The left bundle branch, of course, services and innervates the left ventricle. The right bundle branch, the right ventricle. And there's some disruption indicated here by this purple explosion, showing that the signal can't get through. So the only way for the signal to propagate through the rest of the left ventricle is for it to circumvent the blockage or transmit through the tissue itself. And it often will result in what we see as a bimodal P wave or a bimodal QRS complex. Not P wave, not at all a P wave. Because the right bundle branch works normally, signal goes through quickly. The left bundle branch signal doesn't go through quickly, and so we see this delay in phase. The right ventricle contracting first, the left ventricle contracting slightly afterwards because the signal can't get through as quickly, leaving us with this bimodal QRS complex. Bimodal QRS complex. And this is finally one example of where we can look to the chest electrodes for diagnosis. Most of the other information we've seen was actually in Lead 2. This is one of the first examples where we can look to the chest electrodes because those are the ones that look at the different regions, the different sides of the heart. Remember, V1 and V2 look at the right side, V3 and V4 through the septum, V5 and V6 through the left side or the left ventricle. And so we'll often see, if we're looking from the left towards the right, this characteristic trace. We see the right ventricle first and the left ventricle second with this bimodal QRS complex. Or it's not a classic QRS complex, but you'll see what I mean. As we already acknowledged, the QRS complex is wider than normal. If it were only this initial contraction, indicative of the right ventricle contracting where the bundled branches are intact, it would be a thin, quick contraction. But since we have this overlap and the delay in the signal, it's wider than we would expect. And I'll show you an example of that on the next slide, or in 2 slides. The other way to diagnose this, and when we look at the real-life trace examples, this will be a lot more obvious, and it kind of hits you in the face. You're like, wow, what's happening? The other way to diagnose this is to look from the right side of the heart towards the left and think, okay, if I were an action potential moving through the heart, and I'm looking from the right side towards the left, and there's a delay in the signal moving through the left side of the heart, how would that look if I'm sitting in V1 or V2 watching the electrical activity occur? I have this rush of activity down the septum. I see very quick depolarization of the right ventricle. The last thing I see is the action potential spreading through the tissue on the lateral wall of the left ventricle. That's the last thing I see as the heart contracts. And so the last thing I see is this potential moving away from me in V1 and V2 over here, moving away from me as the heart contracts. So depolarization, positive wave away from a positive electrode gives a large negative deflection. And this might be a bit easier to reconcile on this slide, where if I'm looking through V1 and V2, the last thing I see is electrical potential moving away from me in the lateral wall. I'm going to look for a large negative deflection. And trust me, it's coming up. But I wanted to reiterate as well that the notch or the bimodal QRS complex, if you're on the other side looking towards the right side of the heart, shows the right ventricle contracting and a notch before the left ventricle contracts. Similarly, if you're in V6, the last thing you see is the depolarization coming towards you, right? So we see this last lateral wall depolarizing coming towards V6 or V5, depending on the rotation of the heart. That gives this horned or notched or bimodal appearance. So we can see that here. V5 and V6 showing that characteristic notch. It's not obvious. There is a notch. It's not as nice as the cartoon that I drew on the last slide. But it's obviously there. There is some delay. Maybe this is just a less severe bundle branch block. But a much larger negative deflection in V1 and certainly in V2, as the last thing that you see is the electrical signal traveling away from you in the lateral wall. And this looks fairly large, but it's not even that exaggerated. I'll show you another example of left bundle branch block. We still see the notch over here in V6, not very much in V5 to be honest, and massive negative deflection in V2, as there's a pretty severe bundle branch block and the lateral wall depolarizes last. So positive wave away from a positive electrode gives a massive negative deflection. It's also possible to see this if you place the electrodes incorrectly. So if you see this in lab, don't necessarily freak out. It might be a good reason to go consult your physician or see a cardiologist if you're worried, but it could just be that you placed the electrodes incorrectly. So that's entirely possible.
Have you ever discovered anyone's arrhythmia or anything in lab?
We haven't, even though the reading, the ECG will tell you that there might be something wrong. It automatically diagnoses.
You're about to die.
It automatically diagnoses sometimes right atrial hypertrophy or a different axis than normal. And I largely chalk that up to improper placement of the electrodes. We haven't had anyone with a known diagnosis that has confirmed it with the ECG yet. Maybe one of you will be the first, I'm not sure. We haven't found anybody that has an issue, and there hasn't been anything this severe. And we use the automatic diagnosis as a way to sort of practice your interpretation of the arrhythmias. But no, we haven't had anybody fall terribly ill or give us anything interesting yet. So we'll see. I should also mention that's happening this week in lab for Group A, right? And we want to try the 12-lead ECG while exercising. If that doesn't work, I'm going to default to just everyone can do a resting 12-lead ECG if you want. It's nice to have your own trace and then go through the process of looking for rate, rhythm, axis, hypertrophy, etc. as we get through it. A word about placement of the electrodes. One, they might be in some sensitive areas, so respect, obviously, for your fellow classmates. And two, if you're like me and you have, if the placement of the electrodes is impeded, if you have hair in the way or anything, you might want to prepare the location for electrode placement first, because we don't have razors in lab, and you might not want to do that in the middle of lab while everyone's there. Or you can opt out of doing it. No one has to do, you don't all have to do the 12-lead ECG. But you might want to prepare the area for electrode placement before you get there and practice landmarking on yourself to figure out, okay, well, I can get it in the V1 spot, I can get the V6 spot, no problem. Try to figure out where your intercostal spaces are. You might want to do a bit of advanced preparation before lab this Thursday. And I tell you that now because if I tell you on Thursday morning, maybe it's too late. Maybe not. Maybe you go home in the middle of the day. But something to consider before you get to lab. So let's talk about rhythm. And this is my synopsis, my summary of some of the steps to take in trying to diagnose rhythm, because it's one of the spots where you need to have some insight and creativity, and there's not a clear pathway like there is for rate. 300, 150, 100, 75, 60, 50, like that is fixed. We know how to diagnose or estimate rate. But for arrhythmias, it's not always obvious if the PR interval is long or increasing, or you might forget to look for different shaped P waves, or you might not immediately see that there's two rhythms. Maybe someone has an AV pacemaker, and so there's a P wave, P to P sinus rhythm, and then an R to R rhythm, two independent rhythms. So I always look, one, at the P waves themselves. I ignore the QRS complexes. Are they there? If they're there, what do they look like? Are they always shaped the same? Do they have the same amplitude? Are they peaked? Are they rounded? Are they notched or bimodal? Are they waves? So are they biphasic? Do they go above and below the line, the baseline of the ECG? So I characterize the P waves first and independently, then I move on to the QRS complexes. So one of the first things I want to look at is, I just looked at the P waves. Do they match up? Are there always one P wave and one QRS complex in close succession? Are they related? Are they there in a 1-to-1 ratio? Are the intervals always the same duration, the same number of boxes? The matching is not as easy as it sounds because there's a lot of mismatch that's possible. You can have infrequent P waves, too many P waves, and depending on the type of matching and the relationship between the P and the QRS, it might be indicative of different levels of AV block. So remember we talked about the delay of the AV node, or intermittent blockage of the AV node, or constant blockage at the AV node, which I hope no one exhibits. Next, this will probably come up as you're diagnosing the normal QRS complexes and the normal P waves. But if any of them don't look normal, now we need to try to assess why. Is it because they're all abnormal? Okay, if they're all abnormal, what is it that makes them abnormal? Is it the width of the QRS complex that makes it abnormal? Is it that we have a disproportionately large S wave? Or what is it about the QRS complex that's abnormal. If they're not all abnormal, is it that there's possibly multiple foci, different regions that are trying to spontaneously depolarize? Maybe there's multiple ventricular foci, maybe there's multiple atrial foci. It's certainly easier to diagnose differences in the P wave and identify multifocal atrial rhythm. But you want to compare the characteristics that you've just looked at. In doing that, some of the concrete examples that we just talked about will become more obvious. So you're looking at the width of the QRS complex. Is it always wide? Is it sometimes wide? Is there premature ventricular contraction that just happened and we were lucky enough to catch it while they were sitting connected to the 12-lead ECG? Or is it a more regular, longer, drawn-out delay that's indicative of some kind of blockage of the AV node or below? And this last point does kind of get into a bit too much detail. You can get into detail for any of the above blockages as well, but we just talked about the left bundle branch block being characterized by, I didn't tell you that it was the RR1 pattern, but just the bimodal R wave where we have two QRS complexes that are overlapping in succession, at least from the view in the V5, V6 axes. V1 and V2 much different, and we saw that on the examples already. So P waves, QRS waves, the relationship, and the regularity. Are they always related? Does the relationship change? Is there any aspect that's sometimes there, sometimes not there? And like I said, there's a lot more information on how to diagnose arrhythmias. There's a lot of different arrhythmias that we're not talking about. That's where that resource might come in handy. But we only really care about these main ones. And if I show you a 12-lead ECG on a midterm, for instance, there'll be an obvious arrhythmia. It'll be an obvious example, something that we've talked about in class a few times. So I'm going to break there. We have technically 10 minutes left in class, but I'm going to break there because we're at a really nice break point in the middle of our discussion. We move from rhythm to axis, hypertrophy, infarction. The last three are really nice, clear, ordered, easy to diagnose characteristics. Not like rhythm, which is today's more creative, qualitative, out there interpretation. There's some loose interpretation that you can make with rhythm. Diagnosing rhythm isn't always so easy. But we know how to set up the 12-lead ECG. We've talked about rhythm. We've got that down pat. And rhythm, sorry, we talked about rate. We've got that down pat. And rhythm, we're trying to get under our belt as well. Whether the waves in organization are regular. But that will only come with practice. Lots of information today. I understand if it doesn't make immediate sense, but we'll review and discuss as we move forward. So axis, hypertrophy, infarction on Thursday in preparation for lab Thursday afternoon and your own diagnoses. Any questions before we go? Just a sigh of relief. Okay. Well, have a great Tuesday. See you bright and early Thursday morning.